Okay, one last second. I post the link out on Facebook, and then we will start our children club today. Okay, ready?
Yes.
Okay, so hi everyone. So today is our last children club, not the last, but the last children club of the last 3 months when we introduced this activity to all the members of VietMD. Hopefully, we can continue these activities in the near future after a short break to regroup and get some feedback and further suggestions. The Journal Club today, two math students, Nguyễn Lê Huyền Trân and Nguyễn Thị Phương Thảo, will discuss about a new article came out last May about the feeding for patients with acute pancreatitis, whether early feeding or delay feeding is more beneficial. So without further ado, Thảo, take it away. Hello, go ahead, Thảo.
Hi everyone, my name is Thảo and my partner Chen. We are from VietMD Annual Journal Club. This morning, I will be presenting the study Early versus Delay Feeding in Patients with Acute Pancreatitis conducted by Valerie Vaughn. Our presentation includes 7 parts. We will start with background, nature, aim of the study, methods, results, conclusion, strength and limitation, and the last is discussion. So to the background, acute pancreatitis is common cause of hospitalization worldwide. In Vietnam, the rate of acute pancreatitis patient is increasing. By tradition, treatment of pancreatitis usually consists of fluid intravenous therapy and nutritional support. Oral intake during an episode of acute pancreatitis is believed to stimulate pancreatic associated activity and potentially prolong recovery. So the patient is kept NPO or nothing by mouth. Recently, several reviews suggest that patients with pancreatitis who receive enteral feeding have fewer infections, short hospital stay, and lower mortality than those who receive total parenteral nutrition. So which is the best for patients, early or delay feeding? The aim of this study was to compare length of stay, mortality, and readmission in adult hospitalized with pancreatitis who receive early versus delay feeding. Talk about the method. This study was a systematic review of randomized controlled trial, which, as we know, is the best study designed for assessing the effectiveness of an intervention. Inclusion criteria were randomized controlled trial compare early versus delay enteral nutrition in adult hospitalized with a diagnosis of acute pancreatitis. The study defined early feeding as feeding initiated at or within 48 hours of hospitalization, and delayed feeding as feeding initiated more than 48 hours after hospitalization. Exclusion criteria were studies compare enteral versus parenteral nutrition, compare one form of enteral nutrition with another without varying timing of feeding, or compare one type of feeding formula with another. Let's see the flow diagram of study selection. A total of more than 10,300 citations and studies were received by this source. As peer-reviewed randomized clinical trial and 3 conference abstracts were eligible for inclusion. The next slide. This study divides 11 selected trials into 2 groups. 7 trials with mild to moderate pancreatitis and 4 trials with severe studies that met low risk criteria in each of the 6 domains were designed as having low risk about. Studies were classified as having unclear risk of bias or if methodological data were missing. Talk about the results. This forest also comparison of length of hospital stay for patients with acute pancreatitis randomized assigned to early versus delayed feeding. For patients with mild to moderate pancreatitis, early feeding were associated with reduced length of hospital stay in four of 7 trials. Trial number 26, 29, 30, and 31 with p value equal under 0.05. Of remaining 3 studies are patients with severe pancreatitis. Only one found early feeding to be associated with reduced length of stay and no difference of 2 trials. Another primary outcome, no death were reported in the trial of mild to moderate acute pancreatitis. In group of severe pancreatitis, one study report incidence of death of 8.8% and statistically significant association between early feeding and mortality. Readmission rates were reported in early 2 trial number 26 and 28. Both trials are in group of middle to moderate pancreatitis, and no trial reported a significant association between early feeding and readmission. secondary outcome. Talk of this study talk about gastrointestinal symptoms. It reports that early feeding increasing feeding intolerance, nausea, vomiting, or abdominal pain. Conclusion: early feeding does not seem to be associated with adverse events. It may be a reduced length of hospital stay and gastrointestinal symptoms, and doesn't differ in complication from delayed feeding in patients with severe acute pancreatitis. Next, I will talk the strength of study. This study have several strength including an explicit including an explicit published protocol and comprehensive literature. So that includes literature and span peer review article, abstract, and ongoing trial. Exclusion criteria follow the standard. This study have some limitation. Only 11 randomized trials meet in conclusion criteria, and many studies were small. So the study has limited power to detect rare outcome. Results were contrasted by report outcome, which were highly variable, particularly readmission rate. And only 4 of 11 trials were assessed as having low risk of bias, and 7 trials assessed as having unclear or high risk of bias. The last part of my presentation is a discussion. Guideline from Ministry of Public Health and acute pancreatitis. In this guideline, patients face until abdominal pain is decreasing. A period of fasting is around 3 to 7 days. The result of this study suggests that early feeding may be a safe alternative to feeding in some patients with pancreatitis. So in the clinical practice, I think I will consider oral or enteral feeding for patients with severe pancreatitis within 48 hours after diagnosis. This study has some limitation, and I think I expect further studies to assess timing and protocol of early feeding and early feeding versus delay feeding in patients with acute pancreatitis. That's all.
Okay, so that's all right. Okay, so today we have the Yeah, we have Dr. Dong, have Dr. Jin, as well as our usual instructor and helper and counselor and everything, Dr. Dr. Long Hoàng. So the goal of our journal clubs is twofold. One is for you to practice speaking and presenting, and also the second thing is to learn new knowledge. Oh, Dr. Ho also joined us over here. Awesome. But he missed the presentation. Anyway, so let's do the first comments. Hi, hi and Ho. So sorry, someone else is beside you.
Mình đây có bác sĩ Tuấn, bác sĩ Tuấn.
Hi. Hi,
Tuấn
bác sĩ Tuấn.
bên Việt Nam là bác sĩ mắt bên Việt Nam.
Yeah.
Muốn trở lại. Chào anh. Ok, tiếp tục đi bên sorry nghe. Ok.
Yeah.
Xin lỗi anh một chút. Chân ơi, chân để chị share cái PowerPoint của chị được không? Tại vì cái này hình như bị cái cỗ mất, lại gửi nhầm ấy. Cái đoạn cuối nó hơi bị lỗi ạ.
Ok.
Vâng ạ. Chân ơi, chân ao cái ra để cho chị share cái
Ok. Hậu Hà Tuấn.
Đây nè.
Okay. Yeah, so let's start with the comment regarding the speaking and the presentations. And Dong, first time you try us here, any feedback from you first?
So who present, Dun or Thảo?
Thảo.
Thảo, right? Thảo, I think I understand about 60% of all the word that you say. So I don't know how far along your English is. Anh không biết là em học tiếng Anh bao lâu rồi, nhưng mà khi mà em phiên âm những chữ về y khoa thì có khoảng 60% là anh hiểu, nhưng mà 40% kia nếu mà không viết lên bảng thì anh không có hiểu. Cho nên đôi khi mình luyện trước, xong rồi mình present, mình luyện trước rồi mình phải đi lên diễn thuyết thì có thể là chính xác hơn. Giống như cái slide number 2, đúng không? Là cái exocrine, right? So make sure you pronounce it correctly. So pancreas have endocrine activity and exocrine activity. So I think you pronounce that word incorrectly. So there are words like that is difficult. So I would consult some kind of pronunciation website, like on Google or something like that. They can tell you how to pronounce it better. So exocrine, pancreatic exocrine gland. Hospitalization, I think that's word is difficult to pronounce because we don't have the Z in Vietnamese. So those are the kind of thing that I want to point out. As far as journal club presentation, I think I don't know what the time limit I guess they give you, but I think you could go into more detail in terms of using the method, talking about the statistic, whether that is appropriate or not for the study, whether that would be something that you want to do. The other thing that you want to do is that after your presentation, you can talk about the strength and the weakness of the study, but you also make your own assessment. So you can say that in your opinion, this is a weak study, this is a strong study, and then you can summarize whether you want to apply the data or you're going to change your practice based on the study or not. That would be something that you want to say at the end, to give how much you understand about the article, how much you understand the process, so that people can listen to you and know, oh, she actually understand all this stuff. She is able to digest all the material in the study so that she can make a conclusion for herself, instead of just concluding the article based on what other people they tell you in the article itself. Okay, so those are my general comments.
thank you, Andong. Yes, it's always good to have fresh eyes and ears to help us in the whole process here. And actually, all is very, very correct. About the practice, actually we did have a little practice yesterday, but of course it's gonna be a long process. It's not gonna just happen overnight, but we will keep practicing. I hope that Thảo take it positively. Don't feel that, oh, I only make Dr. Don't understand only 60%, I better give up. Don't do that. Keep practicing.
No, the goal is not for them to give up, but the goal is to point out that
exactly.
that, if you don't know exactly how to say it, they can teach you how to say it, or we can interrupt and teach you how to say it.
Definitely. So keep practicing. About discussing more about the method. At this point, we try to recruit Dr. Long to so that he can spend more time with us to to explain more about the method. We just started. This is quite a new activity, so we build up the knowledge and the skill of reading the article and assessing the strength, weakness, and especially the method of the article. So it's gonna be a long process, but we are working on that. But definitely it's a very important things in the reading the article. If the method is not good, then the results we cannot count on the result of the article if the method is not reliable. And and also you're very right that the goal is the presenter will give her own assessment. But we start with copy first, and we try to understand why they give certain assessment, and they will be on that. Actually, she does have her own assessment, but maybe she just a bit too shy to present it right now. Maybe during the discussion we will let her open up a little bit and give her own assessment about this article. But thanks a lot, Dr. Dong, for your very positive comment. Thảo, any answer, any feedback or any idea, anything from your side about Dr. Dong comments?
Thanks, Dr. Dong. Thank you very much. And I will improve my my pronunciation and my English skill.
Okay, Dr. Long, and any feedback? Just focus on the presentations first, and we come to the content later.
Yeah, okay. So thank you very much for your presentation. It's very interesting. One of the comments that I have given a lot of times to many people, you should number the slides so that when people have questions, they can tell you to turn to slide number X, number Y, and they don't have to say like turn the number where they mention the mortality or something like that. So people win. And in this presentation, the slide about the I think it's about the mortality. Yes, slide number 9, please. Can you turn to slide number 9, please? Thanks. Okay, yeah. So it's really hard for people to understand what the numbers represent. You have primary outcomes are death and readmission. But then I can't understand the study, what is the number below the study, in early, in delay. It's really hard for people to understand what you're mentioning. Okay, right. And Yeah, and also about the slide number 8, you have it's kind of like a forest plot, but if everyone have read some kind, for example, the meta analysis, and it often have, for example, heterogeneity and other things like weight of each individual study contributing to the total number of patients. So in this study, it's not really a meta-analysis. It's just a systematic review, like you try to summarize all the evidence about the current practice of that have been studied, and then you list all of the evidence in the plot. So you should explain about that, and because otherwise people won't understand what the plot really represents. So just some comments about how to clarify what you are presenting on the screen so that people can understand more. Okay.
Mm-hmm. Yes, so slide number 9. Yeah, so she's Thảo get the number from the article and put it together in this table. But yeah, Dr. Long is absolutely right. Normally, people should you should label the table properly. So without you explaining the table, people still can understand it. So that's how it should be. Yeah, so we learn from that. So otherwise, they don't know 24 study 24 is the patient in the study or study numbers, and 11 and yeah. So it's just quite confusing, and especially you not use the pointer that much, so it's quite difficult for the audience to follow which line or which columns you were talking about. Sometimes it's difficult, and and from also the flow of the presentations. We try to talk about that a little bit during the practice yesterday, but still you need a bit more practice, so you can move along better, more smoothly, rather than just jump to a new slide and read about the slide. But it's better than yesterday. I can see that, and also try to each slide try to vary your voice so that you can stretch on certain idea, make people understand and follow you easier, rather than have the same or similar tone throughout the slide. So that it's just a suggestion, but keep practicing.
Yeah, excuse me. Just another comment. So, for example, for this slide, if you so it's very common to see that people don't put a lot of things on the screen, and actually, I encourage people to do that. However, if you in case everything is so simple, when you present, you need to make it a little bit clearer. Like, for example, you can explain that, okay, so now it comes to the primary outcomes about death and readmission. And on the screen or on the slide, we present the number of patients died in like, for example, out of the total number of the patients in this systematic review, and that is the number of the studies that describe the mortality, something like that. So you say that 24 studies describe the mortality, something like that, rather than like you just let everyone understand whatever they think about.
Yeah, so this is very evidence that is a little confusion over here, right? So it's the study number 24 on study number 25. So yeah, if you don't label it properly, people really confused what is 24, 25, 26, 28 is going to be. Yeah, but get the people attention and let them know the general ideas and try to have a better slide with better information and then also try to guide the audience along using some like highlight, some box or some use your mouse so that people can follow you easier. But yeah, it's good to make some mistakes so that we can learn from that. Okay, so Sarah, you have any comments about the presentations to this point?
Everything was already mentioned, so yeah.
Okay, so we just need you to help out more when you have time. Okay, so yeah, so now we come to the second part. We have 15 minutes or less to discuss about the study itself. So yeah, so just like Dr. Long said, it's more about the review, not meta-analysis. So they're not pulling all the results together, but mention about the studies separately. So in this study, they show that either the results is not significant different or favor the early feeding. But any comments regarding the selection of the study, Dr. Long, from like 1,200 study down to 11? They narrowed out to 11. You think that is anything concerning you over here, or you think the selection or the method is reliable enough?
Before Dr. Long answer, can I ask the presenter a question? So it looked like that this study start out with the intention to doing a meta-analysis, right? So in the methods, they have a reason, they explain why it did not become a meta-analysis, but become a systemic review instead. So what is the reason for that? Do you guys pick that up when you read the article or prepare the article?
Thảo, Trân. Hello. Oh, did I mute you? No. Okay.
To be honest, that we don't understand much about the methods.
Okay. So usually in a meta-analysis or systemic review of some type, you want to use very similar study. So the study design, like all the study that they use to look at to come up with a bigger answer, they want to look at very similar study. The way the study design have to be, for example, randomized control, placebo control, or treatment control. So it have to be very similar. And they actually usually they will do a heterogeneity test, or the test to see how similar each of those study is. And then if they cannot find very similar study, then they cannot do a meta-analysis, because they cannot pull the data together to do the calculation on the forest plot that you present on 8. So slide number 8 look like a forest plot, but it actually not, because there's no weighted data and there's no final odds ratio or the relative risk calculation at the end with significant or calculating of alpha and all those stuff. So that's the reason why, because they cannot find very similar study in this group of studies to come up with a meta-analysis. So they basically just turn it into a systemic review instead. Okay, so that's the reason why. Because the study is too different. They look at different things. The population of the patient is different. how they look at the outcome is different, and how they calculate the outcome is very different in all the study.
Okay, yeah, thank you, Andong. Yeah, I'm checked again, but it doesn't seem like they do mention about their intention to start with the meta-analysis first. But I guess yes, it's always most of the time then we wish that we can get the data, but they can pull together so that we can have the strong conclusion whether it's good or it's not. Yeah, I guess when they review all the data, they don't think that they can have enough good information to make the conclusion. And just like in slide number 7 show, they show that the one with low level of bias, just I think on 4 out of on the 11 article, like that means only 4 out of like 1,200 article, they come out only 4. So I guess that yeah, maybe that reason they don't think that the number is enough to pull to become a meta-analysis. Yeah, and they just cannot use 4, so that they have to include those with a bit unclear bias or higher level of bias into that study also. So yeah, I think that that you point out the right thing. Yeah. Okay, and Long, any suggestion about any idea about the study, the method of this study?
Actually, I didn't have a lot of time to read the to do a Prisma review for this. So basically, when you read a report of systematic review or a meta-analysis analysis, we often use the Prisma PRISMA to evaluate the quality of the systematic review. I didn't have time to do that, but basically in this they have mentioned that they followed the Prisma recommendations. One of the things that you might be interested in is how they look for the papers when they do the search on for example, PubMed. So in this, I think in the appendix, they also show the page. What is the page? Sorry, I can't find the page. In the appendix, they also have the search strategy, and they show you the search query that they have used in different library to search for the papers. I think it is very interesting because you can learn a lot about how you search for articles. For example, if you want to search for the feeding methods, they have nasogastric or nasojejunal or enteral, or so they have a lot of kind of different terms to combine in the search query rather than you just, if you type, most of people will think that, for example, if I want to search about parenteral or enteral feeding, I will use only or enteral feeding, but that keyword is not enough to cover all the papers when you do a search. So I think this is very interesting. Or the other example is the randomized word. So in the British spelling, randomized is S, and in the American spelling, randomized is Z. So basically, if you do if you write either S or Z, then you will miss, a lot of publications. So I think this is very interesting when you read the search query and you see that if the authors have been able to cover all the publications that are available in the libraries. So about the evaluation, yeah, this is, we have a limited number of publications that are available to pool. My only concern is that they should report about the you know, the early feeding. What is early feeding? How they feed the patient early, like after how many hours, or the amount of food they start with. I think this is also important, not to you know, not to show the data in this systematic review, but to inform that the future studies should be more detailed about these, and should kind of like, you know, so for the future studies, they often try to mimic the protocol of the previous studies. Of course, they will include more information, so that there is homogeneity across the studies, for the and so the future systematic review can be more robust. Yes, that's my idea. Thanks.
Mm-hmm. Any idea from the presenter, Thảo and Trung? We have 5 more minutes. Yeah, while you're thinking about something to discuss, yeah, I think on table, let me see, table 1, continue on the article. They do mention that different criteria for feedings as early or delay, and yeah, that's yeah, reading this slide is truly show the heterogeneity of the study. They use totally different criteria to feed the patients. Like one is within 12 hours of hospitalizations. Some is immediately. Some is off opiate therapy. Some is within 72 hours of disease onset. So they need to ask the patient when they start having the pain, something like that. And several study is when and they the route of feeding also is quite different. Some is oral, some through nasal gastric, and some is through nasal jejunal tube. So yeah, that is quite many different studies. So yeah, definitely they cannot pull them together. But my only question for this table is whether it's clinically different from feeding oral and feeding patient orally and feeding through the nasal jejunal tube, because seem like one is it into the stomach and the other is bypass the area that the pancreatic juice is coming out. So I don't know, clinically is any difference in these two feeding or not? That part I don't know. I wonder whether anyone can have experience about this.
I don't think we know the answer to that question, because up until recently, I guess a few years ago, you still NPO all the time and you feed orally all the time. But the question whether oral or non-oral in feeding or bypass the pyloric sphincter, I don't think there's really an answer to that. So I don't know the answer to that question.
Yeah, but I guess they have some reason to push the tube that deep, right? Normally they need to do the endoscopy to place the tube that deep. Otherwise, they may just do the half tube. It's just in the stomach. It's the easiest way. So they may think that it makes some difference. I believe, but
yeah, like
really,
the only thing is that when I'm treating people right now with pancreatitis, if they can swallow and eat, I really don't do tube feeding. I do oral feeding. Or in the ICU with prolonged intubation with can't swallow or dysphagia or aspiration, then you are forced to do an DOP-HOP or an NG tube. But the question of whether you need to bypass the pancreas or not, it's not really there. I never think about it that way. So
Yeah, so like when I'm studying in Hungary, my surgery professor, he told me that like if you bypass the gastric, you bypass the regulation control for pancreatic juice secretion, so it let the pancreas rest for the moment. So they prefer as surgeon to like put a jejunal tube rather than like go through the stomach. That's what he explained it to me. So, but I hasn't read about it yet, so I don't know.
Yeah, I don't know whether any like study to confirm that theory, or they just think it makes sense physiologically. So yeah, I think it's
Right,
interesting to
but
know.
this is what challenge that, you know, like the reason why we bypassed the pancreas was the physiology, right? Because at the beginning they're saying that because of pancreatitis, you want it to rest so that it have time to heal, and so you NPO the patient or you bypass it somehow to improve recovery. However, right now we are challenging that idea because early feeding is actually better, right? So somehow maintaining normal gut motility and the GI tract working is better than the damage that the pancreas could potentially incur because of feeding. But obviously the feeding didn't change mortality. Right now we don't have mortality data, but it didn't change anything. It changed the fact that, you know, it challenged the idea at the beginning. It challenged the fact that we don't need to rest the pancreas. We can feed the patient however we want. So I think that idea is outdated, but I don't think there's a data to say that NG tube is bypass it better or oral is better. I think as long as you feed and you keep the GI tract moving, it is better than not. That's my impression. So
yeah, okay. I think we have less than a few seconds.
My question for the presenter again is this: of all the study that included in this review, if we are to do a meta-analysis, let's say all the study, or looking at it, which one have the heaviest weight in terms of determining the recommendation or the outcome? So the 11 study they look at, of all the study, what do you think is the most determining study of all of them?
Okay, I think that we run out of time, and the other people may be anxious to get the Zoom back to us. So Thảo and Trung, write down that questions, and yeah, you can give us our
message
answer.
me on Facebook.
Yeah, and messages on Facebook. I think that's a good question, and you may need to ask Dr. Long to help you with that also. I think that very interesting questions. Yeah, to help us come to the conclusions or some guide for us to practice. And thanks you all for your participation today. You can join us on the next webinar. Happen pretty soon at 8 o'clock. It's about how to talk to patients with cancer. So see you over there. And that's a nice talk, but definitely we need more time. 45 minutes is not enough for a journal club, especially in this interesting article. But next time, see you all, and see you at 8 o'clock if you have time to join us. Bye.
Bye.
Thank you.
Thank you, Ando. Thank you, Long, and thank Trung and Thảo, and
Thank you, everyone.
Sarah.
Thank you. Bye.
Mm-hmm.